Hello and welcome everybody. My name's Karen Eggleston. I'm Director of the Asia Health Policy Program here at Shorenstein Asia Pacific Research Center, and we're delighted to welcome you to our Asia Pacific Research Center for this installment of our series on Asia Pacific Economic Cooperation. Today we have a wonderful panel of special guests joining us, and this is a joint with our Asia Health Policy Program and our APEC series. So we're focusing on one of the I's of the APEC themes is innovation. And here we're focusing in on one topic, which is digital health innovation, which is a topic within APEC, but also much more broadly relevant for reaching those most vulnerable. So we are going to be talking about technology trust and the role of learning from each other, and that's a theme of our whole colloquium series in Asia Health Policy this year, so you're welcome to join us for those events later as well. So we welcome those here in person and also those joining us online who may be viewing the recording later. I would like to start, as I do with our series each year, with our Stanford land acknowledgement. As you all may know, Stanford sits on the ancestral land of the Ohlone tribe. This land was and continues to be of great importance to the Ohlone people. Consistent with our values of community inclusion, we have a responsibility to acknowledge, honor, and make visible the university's relationship to Native peoples. So we're gathered here to talk about digital health innovation. And as mentioned, this is one theme within innovation and actually that Asia Pacific Economic Cooperation economies have been talking about for quite some time, but it's also a more general theme. So here are the questions we're going to be focusing in. We're delighted to have with us both participants from APEC economies, including, of course, the United States and Singapore, but we'll also be talking about digital health more broadly and talking about the economies that are not formally members of APEC, including India, of course, and also for Cambodia. So we are going to have digital health technologies as the promise that we're talking about to strengthen health systems in the Asia-Pacific region. And we're talking about using technology to reach the most vulnerable people of the populations with technology. So we're going to be talking about the evidence for digital health initiatives and what incentive structures and provider skill sets are available, and what is the role of regional cooperation. So we're talking about using digital health to reach very vulnerable, poor populations throughout the region, not only in Asia-Pacific economies, right? So we have a distinguished set of panelists here today. We have, our moderator will talk more about it, but I just wanted to briefly mention you can learn more about their bio sketches later. But we have C.K. Chirovital, who's a Senior Strategy Officer from the Digital Health and Artificial Intelligence Task Force of the Bill and Melinda Gates Foundation, which is devoted to reaching out to help those who are most vulnerable in many parts of the world. We also have, traveling all the way from India to join us today, the very Honorable Kiran Gopalvaska, who's Director of the National Health Authority of India, and is leading important initiatives there to, again, leverage technologies to reach out to those most vulnerable and to better their health, which is a theme that I think we can all agree on is very important and is not necessarily related to the issue of for-profit companies coming in to take advantage, although we will be talking about this issue of privacy and security of data and public and private sector working, again, to better the health of some of our most vulnerable global citizens. This whole discussion will be moderated by Dr. Yi, who is someone who worked a lot in this theme and the issue, and we're very happy to welcome back to Stanford since he was a fellow here. He's a medical doctor by training. He's an assistant professor at National University of Singapore, but also from Cambodia. So we'll be talking about many of the initiatives there, reaching out to the poorest in Cambodia. Again, most of what we're talking about here are examples of initiatives that are broad for APEC, but India and Cambodia, I just want to be clear, are not members of APEC, but we're talking about digital health initiatives there. So with that, I would like to turn it over to our special guest from India who'll be talking about the digital mission there.
A very good afternoon to all of you. I'd like to thank the Stanford University for inviting me here to speak about the digital health mission that we are currently implementing in India, share the experience, and also talk about how collaboration between different countries, different institutions, both academic, non-academic, can actually help in improving the quality of service and the access to the most vulnerable populations in low and middle income countries in particular. So I'll briefly touch upon what this mission is about, how we started, what we are doing, and what challenges we are currently facing, and what we are trying to doing to take it forward. So the India stack, the India tech stack that we talk about, is actually a set of serendipitously developed open APIs built for a digital India. So when we talk about the digital health mission, it was not something that we just did just in the last 2 years. It actually builds on top of what we have been doing since 2009 when we first started our national identity program called Aadhaar. So that was the first thing where we said every individual in the country gets a digitally verifiable identity, a unique identity that one can use to identify themselves as a resident of India. On top of that, in 2012, we built what we call eKYC, Electronic Know Your Customer. This was the first use case of utilizing this digital identity in identifying individuals digitally and without the hassles of one having to provide multiple identification forms or ID cards, etc. This had the potential of revolutionizing how people identified themselves and availed different services. Then we came up with eSign, that is a digital way of signing contracts based on the digital identity that we had created. And on top of that came DigiLocker. DigiLocker was a concept of having a personal locker for every individual to store their digital records, be it certificates, health records, or anything that they want to store in a digital format. And then came our payment revolution in the form of unified payments interface, which actually gave an interoperable and a very easy way of doing payments by simply using a mobile phone. Today, if you visit India, you will see that even a very, very small street vendor has a small QR code placed on his cart, which anybody can simply scan using a UPI-enabled app and make payments. And I'm happy to report that we have actually been able to clock more than 10 billion transactions in a month. That's the kind of transaction volume that is happening on this. And the beauty is it is interoperable. You don't have to use a particular application to be a part of it. You can use any application that subscribes to the protocol and that is integrated with the system. Then came Bharat Bill Pay, which is again an integrated way of paying bills. You didn't have, you may be paying your mobile bill payment, you may be paying your telephone payment, you may be paying your internet payment, you may be paying your utility bills. If the service provider is integrated with Bharat Bill Pay, all of the bills can actually be paid through your regular bank account. And then came FASTag. This was our way of making life easier when you're traveling on a highway and paying the toll. And in all of these cases, the transaction volume, as you know, being of the size of India, is in the order of billions. Then we introduced the GST, the common tax code that actually has again simplified businesses in filing their returns. Now, all of these actually paved the way and built the foundation for what we are calling the ABDM, the Ayushman Bharat Digital Mission, earlier called National Digital Health Mission. So without these, the Ayushman Bharat Digital Mission may not have been possible without that digital identity, without the enabling factors that came in. So I'm showing all of this just to show that any country that wants to build a digital health ecosystem will have to invest some time and energy in building that foundational architecture and foundational services that can actually help on top of which you can provide these services. And the journey of the India's digital health strategy itself started with our national health policy in 2017, which very specifically advocated for deployment of digital tools aimed at integrating health information system and setting up a system that can regulate, develop, and deploy digital health solutions across the continuum of care. On top, based on the recommendations or based on the policy, came what we call the National Health Stack, which advocated that government should build a common set of public goods which can be leveraged by both the government and the private sector to build on top of it and then provide the services to the citizens. The National Digital Blueprint laid in 2020 laid the foundation for the formation of the mission itself, which actually gave the architectural vision, the implementation guidance, and actually told about what are the different layers that we need to develop to be able to launch it. Finally, the strategy document actually gave the real playbook of how the whole digital mission has to get implemented in the country. Out of the effort of all these strategy documents came the ABDM tech stack. In a nutshell, this is what the digital mission stack looks like. And you read this from the bottoms up. At the very bottom, you can see there are two boxes. One talks about the cross-domain digital public goods. That is the ones that I've shown in my first slide. Aadhaar, the identity, the eKYC service, the UPI, Unified Payment Service, and most importantly, the consent artifact. Because when we are dealing with health data of citizens, we want to make sure that data does not get used without or does not move from point A to point B without the explicit and express consent of the individual. The consent artifact, a digital artifact created by the Ministry of Electronics, Government of India, actually gives the users the flexibility and the granularity with which they can decide how, when, where, and what type of records they allow for sharing from one health provider to another provider. On top of that, or along with that, we built what we call the ABDM digital health registries, because one of the important aspects of building a tech stack or a health tech stack is to ensure trust. And for trust, we need to make sure that the participants who are joining this ecosystem are verified and trusted entities. So first thing we said, the data principle, the individual should have a digital identity. We could have used Aadhaar itself, but that's like something like the social security number here that you just can't quote everywhere and it's not easy to use. So therefore, we built what we call Aabha, the Ayushman Bharat Health Account, which is built on top of Aadhaar. So the underlying is still the digital identity, but Aabha is a number that you can actually start sharing and use more freely. We have created a registry for all the health professionals in the country, irrespective of what system of medicine they are in, just to ensure that we are inclusive. We want to include every system of medicine, both traditional and modern. Then health facility. Any facility that provides any health service in both the traditional and modern medicine and has the potential to have an impact on the health of an individual is part of the health facility registry. And finally, drugs. A drug registry, a trusted source of information about drugs that can be used digitally, that is verified, and therefore e-prescriptions or telehealth, etc. is possible. So these are the basic foundational blocks that have been built along with the digital public goods. Now these can be used by government applications also and also by private applications. So that's the basic idea. And then on top of that, we have these three main exchanges or main services that we call, first called the Unified Health Interface, then the Health Information Exchange Consent Manager, and then the Health Claims Exchange. You know, when I talk about ABDM and when somebody asks me, how do you tell what ABDM is about in 2 minutes, a typical elevator pitch. So I say in ABDM we just do three things. One, interoperability of health records. One should be able to share one's health records from one health provider to another provider in a hassle-free manner with the consent of the data principal. Two, interoperability of services. We do not want, or we started with a principle that the stack that we build should be built in such a way that no monopolies get created. We wanted to have a level playing field even for the smallest service provider and who can actually be easily discoverable and whose services can be availed compared to someone who is already an established player. So that is why we built what we call the unified health interface, and the name, as you can see, is akin to unified payments interface, simply because this actually provides a interoperable way of, you want to like find a service provider for one service, you can use an application of your choice, your service provider can use an application of their choice, but still you will be able to discover them. Book a service like a teleconsultation, a physical consultation, a lab test, an ambulance booking, a blood test booking, or a blood bank. You should be able to search the service available irrespective of the application your service provider is on, so that you don't end up in silos. And lastly, the claims exchange. There are at the end of the day, when we talk about universal health coverage, insurance becomes a very, very important aspect. And as some of you might be aware, India currently runs the world's largest publicly funded health insurance or assurance system, providing services to 600 million people of the country. But then that is working on one system. There is also private insurance. And one of the problems with insurance processing, the claim processing in India, is it is majority manual. There's no auto adjudication. The processing cost of one claim is so high that one cannot think of providing OPD services under the outpatient services or daycare services under insurance, because the cost of processing a claim itself would be higher than the claim. To give an example, a typical claim to process approximately costs, and I'll quote it in rupees just for comparison purposes, anywhere between 500 to 600 rupees. And an OPD consultation with a typical doctor in India on an average costs 150 rupees. So now if I have to do a claim for that, and if I have to spend 500 rupees to process a 150 rupee claim, it makes no sense. So we needed standardization of how a claim is made, how a claim is submitted, and then digitization and automation of the claim processing. So the health claims exchange is an effort to bring about standardization and to bring about interoperability of health claims, so that a hospital is not overburdened with the job of dealing with multiple insurance players to submit the claims, and an insurance company is not burdened with the manual process of processing the claim that is more time consuming and resource consuming. So these are the basic three things that we do under the digital mission. So this is what the government has built. The topmost layer is what we call the user application. This is what the user actually sees as an individual or as a service provider. And we have both government and private providers providing these services. And in fact, I would say there are close to 130 different applications that are currently integrated with the system. Less than 30 of them are from government. The remaining are from the private sector. So what we are saying is that here the government is just building the rails. The trains are being run by everybody. And this is where we say that this is the kind of collaboration we need between government, the public and the private sector, so that innovation is not stifled. Innovation is actually encouraged by providing this. So this is how the health stack, the digital health stack of India is built. Then what happens or what will happen by using this? A typical use case, or when we say the objective is to create a citizen-centric view of public health. Just to give you an example of a hypothetical Rani Devi, a 28-year-old female, who may have had different encounters with the health system in the country, either in a reproductive and child health program run by the government, or tuberculosis elimination program run by the government again, or an integrated disease surveillance program that is used for tracking the communicable diseases, or any other government. She may have gone to a government hospital, she may have gone to a private hospital, and she may also have got a vaccination done during the COVID, during the pandemic. Now, all these currently are working in silos. They don't talk to each other. These are records that are generated, but there is no single view of it. So this is where we say that ABHA, the Ayushman Bharat Health Account, the single unique identifier for every citizen, every resident of India that we are giving, comes as a unifier. and creates what we call the longitudinal health record of the citizen. Available, more importantly, on a mobile phone, on a smartphone. So here one can see the record that was created under the reproductive and child health program, or the disease surveillance program, or a government hospital, or a private hospital, or an immunization or a vaccine record. And ultimately, all of them eventually are available for any other frontline worker or a hospital or a doctor to use, so that they can provide better care to the citizen with better access to information about the overall health history of the citizen. So this is what we say a citizen-centric way of providing digital health service by way of the Ayushman Bharat Digital Mission. This is what we are currently doing. And more than 450 million residents of India have an Aadhaar. More than 350 million health records have already been generated. Close to 250,000 health professionals are currently registered as part of the health professional registry. More than 200,000 health facilities are registered with the facility registry, and the drug registry has already been populated with the generic and most commonly used drugs. And like I mentioned earlier, more than 130 different public and private applications have already integrated with the system and are generating records as we speak on a regular basis. So this is the kind of effort that's being going on. However, the ecosystem that we are dealing with is diverse, and each one of them needs a different set of gloves, different set of methods to interact with. So we have the citizens at one end, we have the regulatory and accreditation bodies that ensure that do certifications and that do the whole disciplining of the different sectors and different stakeholders. We have pharma industry, we have the non-profits, we have healthcare providers, both public and private, the health insurance providers, tech companies who are a very, very important partner in this entire effort, and of course the governments, both federal and provincial. Now, these diverse stakeholders in the economy have come in different shapes. India has single doctor clinics and also super specialty hospitals providing 5-star services. And now it's the marginal cost of digitizing for the super specialty hospital is very little, but for the smaller clinic, for the small individual hospital, small hospital, the marginal cost is very high. But the benefits are across the spectrum, and all of them need to be brought in. And then it is important to engage with each one of the stakeholders, because there are fears, there are confusions, there's information that needs to be clarified to them as to how safe the records are, how the consent mechanism works, and how the whole federated architecture that we have built, so that when we say federated, we say that the data stays where it is created. We are not creating a single pool of all health records in one place, and data moves from place A to place B only with the consent of the individual. So the consent manager framework that we have built actually helps that. And at the same time, engaging with the pharma industry, engaging with the providers, engaging with the insurance companies, all require a different set of activities and different approach to do this. And mostly the barriers or the challenges to ABDM adoption to reach that tipping point, I personally believe that such kind of technology innovations usually follow a typical S curve, where you just have to go up to the inflection point where it becomes self-sustaining and it just picks up. First thing is tech reasons. Technological reasons are dependency on ecosystem players. Like I said, there are at least 2,000 different small and large software providers in the country who need to be able to understand what this standard is and what kind of information, how to actually integrate with the system. And plus there is size variation. Some can afford it, some cannot afford it. So how do you do that? So there we are trying to make reference applications that are freely available, tying up with entities who can actually provide the software at a lower cost. And then the ecosystem itself is unfavorable. When we did, in India at least, when we tried to bring in UPI, the payments interface, banks already were digitized. We had core banking across the country. It was only a matter of switching from one technology and just adopting another one. So that was easier. But that's not the case in the healthcare system. We have doctors who are still, a majority of them, writing on paper. So how do you bring them on board? And And there is this fragmented system, like I said, very, very small local providers to very large companies who are providing the system. How do you standardize them? And then the solutions are not, some of them are very expensive. So we are trying to promote low-cost software as a software so that the adoption is faster. And lastly, inertia. Inertia due to various reasons. There's lack of interest because see, with such things, you always have a network effect. The larger the network, the larger the benefit. For example, if all of us are here, if only 2 of us had WhatsApp or 2 of us had a messaging system, it doesn't matter because nobody understands the benefit of it. Only when all of us majority of us start using a common messaging system, then we understand the benefits of the network effect. So that way, we need to bring out, take the people out from that inertia and give them that push to be able to do it. And then there are concerns about accountability. I mean, one might feel that, or a doctor might feel that, oh, you will be monitoring what I am doing on a daily basis. You will be monitoring the number of transactions that are happening. You may be monitoring where my health records are going on. So, allaying that fears. I mean, NHA is data blind. We don't see what's flowing from one doctor to the other doctor. We only look at a transaction that is happening. We don't see what is inside. So explaining this to them. And then finally, bringing all of it together using legal levers or having a sort of a marketing strategy. I mean, we are currently in the digital mission in a stage where the tech problem has been solved. It is now an adoption problem. And I think any country or any LMIC in particular, it will be easy. I mean, like you said, it's public good that we have created, and India is very happy to share all its architectural details and the public goods that we created as global digital public goods. But then, A, they would have to have that underlying infrastructure to start with, and B, eventually they will also should have a adoption or a marketing strategy so that it gets adopted faster, quicker, and the whole thing has to be molded according to the local conditions. But like I said, we are continuously at it. The numbers I mentioned some time back speak for themselves. We are continuously making progress. And with collaborations with institutions like Stanford and with other non-profits like the BMGF and all, we are trying different strategies and different ways of making this happen faster. Now it is only a matter of when, not how. And with the collaboration and the support of everyone here and everyone across the country, I think we can make it happen in India and also make it happen in other LMICs. Thank you very much.
Hi, I'm Grant Miller. I'm a health economist in the medical school in the Department of Health Policy, and we really appreciate your visit, and the work is really remarkable. India has really been a leader all the way back to Aadhaar, and this is terrific to learn more about. I'm just wondering if you could say something quickly about interactions with the informal sector, given that such a large share of the Indian population, particularly lower income populations, seek a lot of their outpatient care still from the informal sector, what the interactions are, and maybe if you perceive any inducement to change choice of where one seeks outpatient care as a result of the digital health mission?
Right. Thank you very much for the question. And the informal caregivers in India are spread across, and they are very large in number. But as you know, they are not what you call the true registered practitioners. And at the end of the day, we would like not to encourage them after a certain point, because we want the citizen to have that quality care. And I'd like to point out that the Ayushman Bharat Digital Mission is just one pillar out of 4 different pillars. Ayushman Bharat umbrella has 4 parts to it. One is the digital mission, of course. The other one is what we call the PMJ, Ayushman Bharat PMJ, Pradhan Mantri Jan Arogya Yojana, the National Health Insurance Scheme. The second one is what we call ABHIM, Ayushman Bharat Health Infrastructure Mission, where hospitals are being built across. The last one, the most important one, is what we call the Ayushman Bharat Health and Wellness Centers. So by strengthening these health and wellness centers, by making them what you call providers of quality service. There are 160,000 of them across the country as of today. And under this mission, under the overall Ayushman Bharat umbrella, these health and wellness centers have actually become the centers that do not only provide the curative part of the service, but also the preventive and the wellness part of it. So by engaging, by utilizing our frontline workforce and revitalizing the health and wellness centers, we are actually trying to bring the patient, bring the individuals under the health and wellness umbrella. And then by having the insurance scheme provides the secondary and tertiary care. Health and wellness centers are going to be the ones that will provide the primary and preventive care. It is a model that has been in place for some time, but by way of digitizing it, the whole data flow actually has become much more simpler now. So it's like currently, at any given point in time, the health and wellness center is taking care of the primary needs. In case there is a requirement of a secondary or a tertiary care need, the PMJI program takes care of it. And then by way of data and by way of what you call digitization of the data, that information is later on sent back to the health and wellness center so that there is this continuum of care, so that people don't fall out of the safety net that we are trying to create by this overall larger umbrella called the Ayushman Bharat mission.
Great, thank you for your talk, and I applaud India for having a third of its population already on the system. And I also am in the medical school at the colloquium, and one of our frustrations is that Asians in general are not well represented in clinical trials. They make up 60% of the world, but only 10% of people in clinical trials for drugs and devices that we use in our diverse populations. And it strikes me that APDM would be a great platform to do recruitment for clinical trials. And is this something that has been discussed at MHA and the Ministry of Health? And what are the views?
Yes. Again, a very, very important question. And because at the end of the day, we also need evidence to be able to improve our policies and provide better services. So what we are currently, one of the aspects or one of the important building blocks of the digital mission is also to create that data, for a lack of a better word, a data lake or a pooling of data from the various sources, and being able to provide and make it available for research, for utilization by the hospitals themselves that they might be developing a new system. So we are currently in the process of developing it, and this data, we want to make it available for research and study purposes. Clinical trials, of course, the physical clinical trials, of course, will have to go through the regular process that go through the medical ICMR, the Indian Council of Medical Research and Department of Health Research. But using the data that has been created, we are trying to create an anonymized data lake so that the personal identification or information does not go out, and that data will be available for research.
Thanks so much, Kiran, for setting very kind of excellent introductions that would form would be the basis of a further discussion. It's a kind of great honors and privilege to be here with these two guys from kind of different sectors. We have CK from the Gates Foundations, who has been working and supporting several community-based projects using digital technologies for improving access to health services and outcomes in marginalized populations. And we have Kiran from the government of India, who has done great jobs, massive digital health programs implementation in India. I believe we have a lot to learn from them. To save the time, I will start with perhaps a few discussion points. I would let Kiran take a little bit of break. So I will go first with CK, because CK has been working quite a bit. I myself have been working with him. I got financial and technical support from his team at the foundation to kind of adapt technologies that had been developed and tested in India and other countries. And this kind of model has been implemented here and there. So we would like to hear from CK about kind of approaches that have been proved to be effective in improving access to healthcare services and health outcomes, particularly in low and middle income countries.
Great, thanks, Ian. So when we talk about digital health, I mean, it can mean many things to many people, but for the longest time, digital health involved the digitization of a health record. So instead of taking that record, taking a pen and a piece of paper and creating a health record there, let's now replace that with a electronic way, initially with personal computers, then laptops, tablets, and then phones. But my team's view is that we can do a lot more with digital health than just creating electronic health records. We definitely need that. That's important. But what my team was really tasked to do is see if we can leverage the power of a device that everybody has in their pocket or will very soon have in their pocket, the mobile phone. And if you think about it, a mobile phone is actually a very interesting medical device, or if you think about all the sensors that it has. A mobile phone, if you think about it, has a camera, it's got a microphone, it's got a GPS, it's got a screen, it's got a stream of data coming in. So what my team was really tasked to do is figure out, can we leverage the existing sensors on a mobile phone and augment the services, not replace, augment the services provided by a frontline health worker. In India, as you know, there's a cadre of frontline health workers. They're called ASHA workers. They are almost always women. They are typically 8th grade educated. And one of their primary jobs is to kind of go door to door providing healthcare to people at their point of care, very often their doorstep. So right now, a lot of the work that they do is just collecting that information, maybe a little bit of counseling. So really we wanted to see, but they do have mobile phones with them. Can we start leveraging those sensors on the mobile phone? And there are examples where they can use the camera on the mobile phone to measure low birth weight babies, to read rapid diagnostic tests, and also with that stream of data coming in, they can combine the patient's health record with some clinical guidance and provide healthcare to triage them appropriately to get healthcare in some of those facilities. So really, our whole mission is mobile phone first, because as you know, in India, in many parts of Asia, the mobile phone is, people don't leave their home without it. So why not use that as a mechanism? And again, to be very clear, to augment, not replace health professionals.
Thanks so much, CK. I think I agree with CK. Once it's come to digital health, there's a lot of confusions out there asking what digital health really means. What's the difference between digital health and health information, for example. But in the end, our goal is to improve access to health services and improve the health outcomes of the populations. And perhaps just I want to add on, or perhaps try to kind of like market my work in Cambodia a little bit. I use like kind of like digital health platform developed by CK's team and collaborators in Gujarat, India, and now we have developed kind of like materials to adapt this kind of platform to support. In Cambodia, they are called village health volunteer groups, which is very close to community health workers elsewhere. And so the goal is to equip the community health workers with these kind of technologies that would, support them to register and follow up pregnant women, newborns, from the conception through to delivery, post-delivery, to ensure that mothers and newborns would receive, recommended prenatal, delivery, and postnatal care. So this is something we are now working on, and I hope I can prove that the approach or the model would be effective and cost effective, so that I can get support from him more. This is I'm hoping for. Perhaps. Anything to add on this kind of evidence in terms of using digital technology to support perhaps more like around, improving access to services and health outcomes among marginalized or perhaps in need population?
I think what CK has mentioned about using the mobile phone for capturing information or capturing different metrics that can actually be part of the overall service that a health worker is providing is a very, very important part of the whole digital health effort or initiative that we are doing. And not only that, many a times the mobile phone actually is in the hands of the individual themselves. The most of the data actually can start happening from there. In fact, teleconsultation as part of the digital, digital health services. Today, we have one application called eSanjeevani that the government runs, where more than 300,000 teleconsultations happen on a daily basis. And they are simply happening because there is a mobile phone with the individual, a smartphone, and someone is simply logging in, looking for a doctor who is available, and then availing that device. And this actually, by making this access easier, helping them easily find a doctor and get the service, we are also probably addressing this whole issue of the informal doctors or informal providers who may or may not be providing the best kind of services. But here, by making this digital, by making this available on a mobile phone, we are improving access, and at the same time, we are also ensuring quality. Because the moment it is digital, it can be measured, it can be monitored, and all the actors in the digital ecosystem can be can be verified, and we can ensure that these are actors who are trusted entities. So that's how I think using innovations that are funded or that are being developed across the world and coupling them with frameworks that we are building at a country level can actually improve access and also quality at the same time.
Thanks so much, Kiran, for the additional comments on this. Perhaps I want to come back to CK a little bit because we have concluded the interventions and evaluations of the digital application in India. Mm-hmm. Can you please summarize just perhaps a few kind of like scientific evidence of the effectiveness and cost effectiveness of the application deployed in India?
Yeah, so in India, it's been very interesting. So India, as you know, has a federal structure. So every state has some responsibility over the health. So the Gates Foundation has been doing a lot of work in Uttar Pradesh and Bihar, and also in the state of Gujarat. So in Gujarat, we found an interesting software platform. It's called Techo, developed by a company called Argosoft. And we found that it was being used across the entire state. So a single platform used by all the community healthcare workers and at the primary healthcare clinics. So for us, that was very interesting to see if there was one platform, what benefits can you get when all of that data is pooled? Because the key for the patient is they want continuity in care. They don't want to go and get seen by one doctor who then sends them for a diagnostic test, who then sends them potentially to a hospital, and they come back, and that loop is never closed if there are multiple software systems, right? And this was pre some of the ABDM work that Kiran's been working on. So we saw that platform as an interesting, we saw that software as an interesting platform. We wanted to see if we could replicate that in other places. So if we replicate it, then some of the interventions that you can build on top of the platform becomes a lot easier to do, and then you can get really those benefits of scale. Because what we've seen time and time again, not only in India, but in parts of the world, is when there's broad agreement, yes, we should do something with digital health, people tend to start from scratch every single time. Oh, let's build a digital health platform. And you can see it in country after country in LMICs that not only does every country have its own platform, within a country, by disease, there are siloed platforms. There is an HIV platform, there's a TB platform, there are multiple platforms there. So we wanted to see if you could have that continuity of care, then you can start to do really interesting things, use AI to analyze the data, start leveraging those sensors. So what we did as an experiment really in Cambodia was a little bit of an experiment for us to see, can we take a platform developed in the global south in India, which seems to have success and scale, and use the bones of that. It still needs to be, the language needs to be changed, the workflow needs to be changed, some of the aspects of the software need to be changed, but the basic bones of that, can we take that and deploy that in another country? Because then that country doesn't have to start from zero again. They can build on some of the hard work that's already been done. So we've actually deployed that platform in 2 countries. one in Cambodia and the other in Nigeria. We intentionally picked very different geographies with very different workforces, very different issues. And so far, they seem to be very successful there. And even within India, that TECO platform is also being deployed right now in the state of Uttar Pradesh, so UP. And that state alone has a population of about 300 million people. So that's almost a country unto itself there. So really our effort is, if we can build platforms or multiple platforms that at least work on a common infrastructure, then you really start to get those benefits. Otherwise, it's too expensive to develop a platform from scratch, country by country. And if you just think of, Windows, Mac, Android, Apple, what we want to do is really use the apps on that platform. And if every app owner, if they wanted to create a map system, had to create that platform from scratch, nobody would create that. So let Apple and Android and or Windows or Mac take care of that basic infrastructure, and then you can engage the private sector to come in and build the user-facing application of that. So that's an experiment. We're trying that. Seems to be successful so far. If Sian continues to deliver.
I agree, and I hope it's going to be successful in Cambodia as well. And I agree that we have to understand the needs. It's always possible to kind of bring in new technologies or innovation to new countries. But when it's come to the adoption of this, we need to understand what we need. And we are now discussing this kind of like digital health landscape, particularly in low and middle income countries. So we need to understand the needs. So perhaps that would link to the second point about what we need in terms of infrastructures and skill. And from your presentation, Kiran, you presented a great job. In India, we can see huge scale and also a great innovation there. What would be your kind of expert opinions once it's come to adoptions of these kind of technologies to countries or setting with some limited resources?
Yeah. Like I said, adoption is actually the difficult part. First, the tech part is relatively easy to solve because you can always use a solution that was tried, tested somewhere, slightly modify it a bit and start using it. And I think funding it also is easier because it's mostly like a one-time investment. It's only maintenance, which generally countries should be able to take care of. Adoption becomes a bigger challenge because, like I mentioned in the presentation, the landscape becomes very diverse. The players, the stakeholders that I mentioned, that big circle of so many players that are coming in, bringing each one of them to the table and understanding their requirement and then convincing them that it is good to come here. There is value in coming here. So the whole adoption game is actually creating value for every player to be part of this. Even for example, UPI, the Unified Payments Interface that we currently are running so successfully with 10 billion transactions, nobody was interested to come there initially. Nobody was interested. It was only after a push was given by the Reserve Bank of India to the banks to first start and create that ecosystem. Then suddenly the people realized, oh, this is a very good thing. And then now everybody wants it. Entities who are not part of it, entities who are not interested in it, are now actually clamoring to be part of it. So you have Google, you have PhonePe, you have Paytm, you have anything. And then every other payment website also gives you an option to pay via UPI, the Unified Payments Interface. So because value was shown. So from a situation where nobody wanted to be part of it, we are in a situation where there is what we call the FOMO, the fear of missing out. So that is something probably we'll have to create. And for that, there are like different things. One is availability of the system, the solution itself. Then comes the affordability of it. Whether the solution is affordable. Like I said, a small player would be eager to probably use it because he or she wants to modernize and use it. But then the marginal cost for him or her would be very high. Whereas a larger player for whom the marginal cost is much lesser will ask more questions but will do less. So how do you make it accessible for the smaller player so that at least you are covering it from that side? And one of the ways of doing it is by setting an example, by turning the government systems itself into being a part of it. Like we have made sure that all the government programs are ABDM enabled. We are ensuring that all government hospitals start using ABDM enabled health management information and LMI lab management information systems. That is the demonstration space. And then making available these low cost solutions, solutions that are plug and play, so that you don't have to like invest a lot in actually trying, simply like creating an email address on Gmail. It should be as simple as that. Trying to make such kind of solutions available. And then democratizing the whole effort of whole idea, I mean, this whole thing of support. At the end of the day, let's say you are a tech solution provider. You are a small startup. You have a solution, but 10 people use it. You are able to support it. But tomorrow when 1,000 people are using it, you need to have that kind of a backbone to be able to support it. So how do you support such smaller players so that they can innovate, they can improve their solution, and then that becomes more and more prevalent, more people start using it. So how do you support them? So I think by skilling, by making it accessible, by making it affordable, and by demonstrating that this works, is a way we can improve and drive adoption faster.
Yeah, I think that's great thoughts. But that would link to perhaps another question. From the academia survey, I believe like once we think about like testing, proving that such a model works would be one stage. But more importantly, in the end, we want to have kind of like the scale up, the adoptions of the approach of models. By the government. So as being someone in the academia, we think about proving the impact and also perhaps like the cost effectiveness of the approach, but convincing the government to take or to kind of like adopt that approach is even more challenging. So perhaps the question perhaps go to both of you from the funding agencies, also the government, how this works.
I can talk a little bit of that. So the Gates Foundation, our role is it's a private philanthropy. It is to provide catalytic funding, not to run the health system of a country. We don't do that, and we shouldn't do that. It's up to the country to run it. But what we can provide with the resources that we have is if there's a new technology, if there's an innovation that needs to be tested out, it needs to be de-risked. That it may not work initially, right? And it would be unfair to ask LMICs to kind of invest a lot of money in technology. If it works, great, but it may not work. And a lot of technology does not work or does not get adoption. So really, we see our role is to provide that catalytic funding, de-risk that technology at the early stage. When it's proved out, then we hand it over to governments, civil society. They need to kind of figure out how to implement that skill. And that's when I turn it over to the government.
To the government.
Say, here's this technology, it works, you take it to scale.
Yeah, I mean, just before this talk, we just had a very interesting conversation with, I think, one of the postdocs here. This was about, okay, I have a solution, but then how do I make the government adopt it? Because the frontline worker is already doing a lot of work. The frontline worker is already collecting a lot of data under different programs. Now this is something different that I want to bring in. Even if the government wants to take it, the frontline worker won't allow it. Because nobody wants additional work. So any solution or any technology that we want to bring in has to be embedded into the existing program or actually has to be part of it. Like for example, if you say that, okay, I have a tech solution that can do anthropomorphic measurement of kids and then they can say whether the child is malnutritioned or severely acute malnutrition or something like that. So now the way is to actually show how it can replace the weight to height and height to age ratio and the WHO chart that the frontline worker is currently creating and say that, no, you don't have to do all that. You just do this, you scan the child from 6 different sites and you get the report ready. Then it will get it will get adopted. There will be initial costs, there will be initial hiccups, but you have to get the government hooked onto it. Because once the government, and most of the time, the political executive is smart enough. They really pick things up very quickly, and I'm sure it is not only true of India, but also true of other LMICs also. Politicians are smart. They know the pulse. They know what my field worker will accept and what they will not accept. By showing that value, once you hook them onto it, even if it is 4 or 5 cent extra that they may have to put in, they will put in because they've gotten used to it. Now everybody wants it. I mean, otherwise, it would not have been possible to just give away tablets to every frontline worker in India. When the first time there was a program called Anmol, this is a mobile app. The services provided by a frontline worker under the reproductive child and child health care. Earlier they used to fill up a form and they used to do a lot of paperwork. Then came one app called Anmol, short for ANM Online. ANM is Auxiliary Nurse and Midwife. That is the name of the frontline worker. Now, when this came, the first question was, oh, where will the procurement come from? Where will the money come from? Believe me, there are budgets that are lapsing because they have not been able to put into better use. So if we actually say that, oh, now instead of filling those long forms and maintaining that big register, this app will actually be the one that will help you maintain the thing, then it will work. Then the initial investment will happen. The training will happen. The frontline worker will demand. Same thing, like for example, when we are trying to sell or when we are trying to digitize a small hospital or a single doctor clinic or a doctor and a helper clinic, to our surprise, we realize that it is, even if the doctor, once they start using it, after a point in time, even if the doctor wants to change, the assistant won't allow. Because the solution has made his or her life simpler. So that is the whole thing. The whole idea is to get them hooked onto it. Then we will find the means, resources, and the will to continue it.
Agree. I have observed the same challenges, and particularly what you mentioned earlier is about the burden of community health workers. They are mostly volunteers, and everyone goes with them. Everyone goes with more work, more technologies, more training. So that's something we have to kind of like understand before rolling out this kind of like new technologies as well. I think coming back to your work in low and medium income countries, again, our end goals of using the technologies would be to improve access to health services and improve the health outcomes of the population. But we researchers sometimes have been blamed by the local people that you just design those kind of like intervention from the heavens, which is not probably applicable to the local context. So in that case, from your experience, what would be the best approach using, or perhaps another way to ask the question, perhaps how technologies can be employed to involve or to empower the beneficiary or patients so that they can be kind of more involved in the process?
So I'll give you an example and how important it is to have that local context. So it may come as a surprise to most of you that most Indians, at least it used to be the case, and definitely in rural areas, most Indians are not born in their parents' house or even in their parents' town. They are born in the maternal grandparents' house, right? I was not born in my parents' house. I was born in my maternal grandparents' house. And there's cultural and social reasons for that. The mother wants to be surrounded by her family, her mother, her aunts. So typically in the 3rd trimester of pregnancy, the pregnant woman will move to her parents' house, and the baby will be born there. Now, when the 3rd trimester is a critical time for the mother and child. And when some software is designed, they normally take the details about the woman and they register her current address. Now, if you continue to use that, come the third trimester, that woman is not going to be at that address. She might be 100 kilometers away in another village. So a lot of the software developed in India, it's different in different states, but a lot of the software developed in India takes that into account. So when they register a mother, they know not only to take her current address, where she probably lives with her immediate family, but also her maternal address. And the way the software is designed is really, in the third trimester, automatically the software throws up a flag in her current address and throws up another flag in her parents' house address. So the healthcare worker in that jurisdiction knows that we have an incoming. There's very likely to be a woman coming in who is not in our current register, but is suddenly going to appear and is going to be at this address giving birth to a child or run through a third trimester. So that kind of insight, when software is developed, as you mentioned, if it's developed in isolation without understanding that social context, you'd lose a huge portion of the population. You'd lose that effectiveness. So I'm a big fan of making sure that the software, the people developing that software at least have context understanding of what that country's social norms, mores, kind of family rules are. And that's been working really well, that kind of throwing up a flag here, throwing up a flag there. I know for certain if this software was developed in the global north, they would totally have missed that, because that's not something we kind of consider at all, that your permanent address is not where your child is registered.
Thanks so much, CK. These are great examples. I think it's easy to understand as well. Anything to add on, Kiran, from your experience working with community?
I think the example that CK has given is a very, very valid example, and then making the solution simple, keeping it simple is also a very, very important part of it. The Anmol software that I am talking about, it didn't succeed everywhere. It succeeded only where the frontline workers were able to comprehend and use it. Even within the state, it didn't work very well. So the idea is because at the end of the day, it was simply a reproduction of what was being registered, filled in the registers. So there has to be a proper process reengineering before you actually convert it into a software, into a system. So unless that is done, if you are simply just translating what you are otherwise currently doing into in the paper, and you just translate it into a tablet, what is the additional value? So I think taking care of such re-engineering also becomes very, very important. And when we are re-engineering, these things come in.
Yep.
This whole idea of taking care of local conditions, local issues. So I think that's a very important part.
I understand, yeah, and agree on that. I think to save some time for Q&As, we would come to perhaps the final questions, and could be an important one as well, because we are now trying to understand the landscape of digital health in Asia and the Pacific, perhaps focusing on the low and middle income country in the regions. And we understand that within these countries, some are far more advanced. Countries like India, Singapore, Brunei is also one of the kind of most advanced once it comes to digital health. And in your opinion, working with kind of different governments or funding agencies, development partners, what is your kind of expert opinions in terms of supporting countries, particularly those with kind of perhaps like weakers or less well-equipped technologies? How like country may work together to support one another in kind of advancing digital health technologies in the region?
I think, like I mentioned in the presentation, the whole objective of creating the different digital goods that under the digital Ayushman Bharat digital mission was to make them public goods, not only for the country but for the world. So we've done it with Aadhaar. We've done it with our effort in Aadhaar. The whole what we have done is we have like two models. One is homegrown companies who have worked on it, who know the technology, going and implementing it somewhere, where we actually have shared the source code itself with the other country. That is one. Another is doing a transfer of technology and training the homegrown, the other countries, tech companies, whatever kind of infrastructure they have, so that they can build and then modify it on their own. And thirdly, using standards that are accessible and acceptable worldwide. Like for example, the entire digital mission is built on, the data exchange is built on FHIR, FHIR, the Fast Health Interoperable Resource. So because interoperability is one very major important thing, and today we are talking about interoperability within the country. Tomorrow there has to be global interoperability. And even within interoperability, see, there are three layers of interoperability. The transport level of interoperability is there. It is simply data flowing. That is cracked. Then comes the structural interoperability. Being able to read, say that, okay, A, B, C, D fields are coming in and I am reading it as A, B, C, D fields. The third part is the semantic interoperability. That is something that we are yet to fully achieve. So by being able to use standards so that all levels of interoperability are achieved is also a way in which this kind of integration can happen. And then ultimately, what you call creating forums where this experience can be shared, these digital public goods can be made available for anybody to use and take them further. This happened during the COVID times also. The what you call the vaccine data exchange had 3 or 4 major standards. One was the US standard, the other one was the European standard. Then we had something called the DIVOC standard that was used by some countries in the Southeast Asia region. Then Thailand had one, but then ultimately agreeing to have one common standard that the WHO has said that, okay, this is what is going to be the standard everybody would follow and comply with, so that data becomes easily interchangeable. So that becomes very important. So I think countries like India who have matured this, who kind of have this experience, and India has always shown willingness to share it. And I'm sure other countries like Singapore and Brunei, for that example, I think we should all probably come together, exchange ideas, and share this public goods. At the end of the day, we need not reinvent the wheel again and again. And we are more than willing to do that.
Sharing experience, expertise to develop data system.
In fact, I have to mention this. The digital health blueprint for Maldives and the digital health blueprint for Bangladesh are being developed by the same person who did the digital health blueprint for India. He is currently consulting with the WHO. I was speaking to him few days before coming here. He said, Kiran, you know, the blueprint for Maldives and Bangladesh is actually coming up much better than what it was for India. So I said, yes, sir, experience. We've learned from this. So that is where the resources that have gone into, the people who have gone into building what was done for India are now doing it for the rest of the world, and where organizations and institutions like academic and also multilateral organizations should play a role in making sure that these resources are best utilized across the world.
Thanks so much, Kiran. So, any adding opinions on this?
Just the final point, like, don't let your infrastructure, your stack reflect the government department structure. Very often, if the government is set up in a particular way, you've got, surprisingly, the apps also tend to exactly reflect the organizational structure. So, I think it's easier said than done, but think about putting the patient at the center, not funding flows, not departments, not silos as the organizing principle.
Yeah. Thanks so much, Kiran and CK, for the great insights.
My name is Nagesh Maligari, and I'm a biomedical engineer who is now focused on the business side, driving strategy and implementation work. And just hearing about the work which is being done is fascinating. And if we are able to draw the parallel between what's done in UPI in terms of financial payments and try to kind of like bring that in, I can see there is a lot of potential, but I think it's going to be much more harder and slower because it's health data and it's not just transactions, right? But I wanted to hear, taking similar parallel, right? How are companies like Google and Apple being in Silicon Valley, and of course, the primary operating systems on the mobile phones, how are they, I mean, are you partnering with them? How are you leveraging their tech? Because Apple has personal health records. And from Android side, I don't know what kind of work is possible. I don't know if you can comment on what kind of partnership and what kind of support you can provide.
So I'm assuming that question is to me?
To you, yeah. The boss.
Right, right. So as far as Google is concerned, Google actually has made SDKs or those wrappers which actually are helping HMIS solutions to create the Fire bundles. So the whole idea behind ABDM is that you use whatever system you want. The other fellow also uses whatever system he wants. But when it comes to interacting between the two, when you say that you are integrating with the ABDM system, you should be able to do mainly three things. One, create an ABHA for an individual when he hits the system. Or if it is already created, retrieve it. Because you ask for an Aadhaar or the identity, because that is a basic identity, and retrieve it. Two, you should be able to create a health record as a Fire bundle and link it with the ABHA of that individual and share that link, just that link information with the ABDM system. And third, you should be able to access a Fire bundle that someone has created, take it, consume it, unpack it, and use it in your system. So this is basically what happens when somebody is integrating with ABDM. Google actually has built wrappers, those are free for use, that can actually do the conversion or creation of the bundle and also the unwrapping of the bundle. So that's the kind of collaboration we are having with them. AWS is also one of the major providers of this kind of wrapper services. Apple is Apple. They have their own personal health record system. And this is where I think this whole idea of interoperability has to come in. So, I mean, I think India, by virtue of using Fire in India, we have actually made it probably the biggest, standard that is being used for exchanging health records. So all of us have to agree to one standard. Ultimately, today I am using Apple and tomorrow I start using an Android, and if you say that whatever records are there in my Apple phone are lost, or I have to continue using only an Apple system to be able to access it, then probably you are violating my privacy norms. You are actually denying me access to my own records. So I think they have to come up and actually start a way of being able to share this, bring about interoperability with the data. At the end of the day, I mean, it's like you will still be providing stellar service, you would still be providing good service, and you will have your customer base who are actually hooked on to you because of the kind of services you provide. But being able to share the record so that the other person who is not using it or the other service provider who needs to access this data to provide you better service, I think in the interest of the patient, this has to come in. So we are already collaborating with Android and AWS, Azure, all these major cloud providers. Apple is something we need to work on.
As long as we kind of find the common thread, right? It's more about exchanging the core information. It doesn't matter if it's coming from Android or iOS, right? But I don't want to take more time, but one more question. From an adoption perspective, the big part of it is user experience, and it's about changing habits. It's about switching costs, right? Like, are you working with both healthcare workers and certain user groups? Please. Yeah.
So a large part of what is done in ABDM is actually community-led. we have, I mean, we have our own Silicon Valley, right, in Bangalore. So there's a big group of community, what you call contributors who actually, whenever we want to build a standard or a protocol for the claims exchange or for the data exchange or for unified health interface, these are standards we are building along with the community involvement where they are actually helping us. As for the user experience per side, again, the tech companies, the health tech companies in Bangalore, Pune, Hyderabad are all like, I mean, we are like having these small little challenges of hackathons and other things where we are saying, okay, please come up with a solution to make life easier for a doctor to enter the health record. So there are solutions coming in. And what we do there is we have a specific partners space in our web page, because endorsing by government has certain value, right? So we actually list them in our page saying that these are our partners and these are the kind of solutions they are providing. And lastly, even academic institutions like AIIMS, the All India Institute of Medical Sciences, the premier institute in India, there are practitioners who have years of experience who have built clinical decision systems based on their experience. And they want that to be used by everybody. And the best ways is to convert it into an SDK, and we are hosting it on the NHA platform and then saying, okay, this is something that is available. And any HMI system who wants to use a CDSS can actually simply hook onto it through an API or simply use the SDK. And lastly, collaborations with, so like we had a chance to meet the director of Digital Health Policy Center today. And I think places like Stanford, the tech centers, actually should help us in actually bringing about building software that are more user-friendly, less invasive, simpler to use, so that the adoption becomes more quicker. So that's how we are doing it.
I'm Charles, and I am actually a research scholar at the Cyber Policy Center of FSI. Well, between 15 and 20 years ago, I was actually a member of the board of the health system in Hong Kong. And at the time, I was also very involved in their development of their clinical management system and so on. So when I look at digital health, more in addition to providing all the health outcomes and improving safety, patient safety, and so on, part of it, the biggest challenge that we face was actually privacy, because it has to do with trust of the patients and the whole citizenry to the whole system. So we've seen over the years that there have been quite a number of these incidents in countries in Asia, such as Singapore, Hong Kong, and Taiwan, and so on. And my question is, how do you see the importance of the legal and regulatory infrastructure? You mentioned infrastructure. I think that is actually also part of it, the infrastructure. How do you see that going hand in hand with the technology and the health side of the development, so that we can maintain trust? Because I've seen things go wrong, and that will be a big issue. And I would imagine there would probably also be a similar problem in global South countries.
Again, a very, very valid question. And I think security and privacy were always at the core when the ABDM architecture was being designed. And like I mentioned, first thing we did was we said we will not pool data in one place. The entire ABDM thing is built on what we call a federated architecture. So data actually remains where it is created. I mean, today I go to hospital A, they have their own system, my data stays there. Tomorrow I go to hospital B, they create a health record for me, data stays there. What we actually keep is only a link that, okay, my health ID has a data point in hospital A, another data point in hospital B. Whenever data has to move from A to B, the consent artifact that I mentioned actually comes into picture. This consent artifact is a beautiful digital artifact built by the Indian government, the Ministry of Electronics, whose underlying is Aadhaar, again, the digital identity. And the consent artifact has a certain level of granularity. You can actually decide what is the duration of data that you want to share. You want to share last 2 weeks data, 2 years data, lifetime data? That is one. Second, what is the type of data you want to share? Because under the digital mission, we have 7 different health data types. You can choose to share only your immunization record. You can choose to share only a prescription. You can choose to share only a clinical notes. Then, for how long this consent is valid? Your consent, you say that, oh, it's only valid for 1 day. Data can be pulled after that. Lastly, you may have data from n number of providers. You can actually choose whose provider data you want to share. And finally, while Abha, the number is 1, we have what we call something called an Abha address, which is like an email, which is kiran@abdm. And I can actually create kiran@abdm, Kiran Gopal at ABDM as 2 different addresses linked to the same number. But I can choose to add, let's say, I have some data, some health data that is confidential that I want to share only with one provider. I can link that data to one address and the remaining data to another address, and only share the address, because at the end of the day, the data actually is linked to the Abha address of an individual. So that is the kind of granularity you give. Then on the regulatory side, we have passed what we call the DPDP Act, Digital Personal Data Protection Act, that actually empowers the individual on and lays certain what you call conditionalities and requirements on any data fiduciary who is handling with data, and also someone like the National Health Authority who is not holding any data per se, but is acting as a consent manager, or who is running the consent manager. So we are so that act relays on specific responsibilities for this. Plus, we have what we call the DEPA architecture, digital data usage for what is it called, data monetization activities. So how the architecture actually gives you the framework of how personal data masked, or to the extent of to which an individual is providing permission, can be used for other activities other than what it was primarily intended for. So that is where the data monetization part comes in. So these frameworks are there that are that are providing the enable framework. And of course, the National Health Authority itself has framed what we call the data management policy, data retention policy, and then what you call the market rules for anybody who is participating in the unified health interface. Like in the UPI also, you have certain market rules that everybody who is participating in UPI should stick to certain rules. Lastly, the trust factor. Nobody can come and participate in the ecosystem unless you are verified. You have to register yourself either as an individual, that is through the ABHA, or on the HPR as a professional, the health professional registry. If you are a facility, you have to register as a health facility registry, and then like the drug registry, of course. So only trusted actors can actually participate in this. So there are different, this is how we are building it, and fortunately we have been able to, we've been successful so far, and we'll of course learn. Things will evolve, and we will only improve it further if required.
It's really fascinating to see so many of these innovations in India, something I've seen actually just in my relatively short life in growing up. I'm a PhD student in economics, and I guess my concern is a bit related to the previous question, but when we sort of, when we get to the top of the S-curve and we have a lot of these products, what's sort of the plan to regulate a lot of the private usage, which might be legal, which might be sort of in line with a lot of these engineering frameworks, but might be on net harmful to the users? So things like, you can think of misinformation on WhatsApp, or potentially inducing people to take loans on these payment platforms, which they might not understand, but companies would be able to do. So what's kind of the regulatory framework for those type of problems that might arise later?
I can just say that as we work globally, the Gates Foundation works across the globe there, and we have to be very careful about not dictating or even trying or be perceived as dictating to a country how they should manage their privacy, their regulations. We we tried our best to adhere to kind of what we think is the right thing to do, but at the end of the day, we leave it up to that government, that civil society, those NGOs to kind of figure that out for themselves, as it should be. We just kind of de-risk that early stage technology there. But we do make sure we kind of give them best practices. Here's what you should consider. Off late, there's been a lot of, what rightly or wrongly, I won't say it's right or wrong, what's called data nationalism, kind of concerns about a country's data being stored on a server in Silicon Valley as opposed to within the country. And I think the tech community has reacted to that as well. AWS has now opened up servers within different countries, and then worked very closely with the government to make sure that the government can monitor the data, make sure it doesn't leave the geographical boundaries. That does, in many cases, for some of the AI projects we work on, make our life very difficult, because with AI, the data needs to live in the cloud. We need to be able to access it. Researchers need to be able to access it. But we always adhere to whatever. So even if it comes to not running it on the most optimal server, it would be much easier to run a particular instance in Nigeria on an AWS server, but the government of Nigeria has certain rules, so we're running it on a local government-approved cloud service provider. The uptime is not as great as AWS, but that's the country's rules. We fully respect it.
Thanks. Over to you, Karen, for the conclusion. I think so.
Well, thank you all so much for coming. We've come a long way in this field. There's still a long way to go. So at the beginning of a conversation, please join me in thanking our wonderful speakers today. Thank you so much.
Thanks so much.